US, 5 or 6 times for the valve itself. The overall cost
Japan.
is somewhat similar because of the way we calculate healthcare costs in the US. It has a lot to do with time spent in the hospital.
Good afternoon, ladies and gentlemen. This is a live case lecture session for this afternoon. As you know, we have 2 live cases from Asan Medical Center. Before starting our sessions, I just wanted to introduce my co-moderator, Helen. Say hello to everyone.
Hello to everyone from France.
Nice to see you. And the other guys, I'm sorry. Oh. So where is he? Dr. Washin Vukkari from Bangkok? Thailand, Bangkok.
Good afternoon, everyone.
And the other, James Flaherty from Chicago. Good to see you. And Junhong Kim from Busan University. Where is he? Okay. And Yoshihiro Morino.
Hello, this is Dr. Morino. Nice to meet you.
Thank you. And Junhyuk Oh.
Thank you.
Thank you. And Shin Shen Sung from Taiwan. Yes. The Weishan In. Yes.
Hi.
Welcome aboard, everybody. Let's start connection to the operating theater in Asan Medical Center. Okay. Oh. Good afternoon, ladies and gentlemen. We already started our session. Why don't you introduce yourself by yourself?
How can we best do that? Well, first of all, thank you very much. And my name is Eberhard Grube. I'm from Germany. I'm here with a wonderful team, good friends, excellent operators. Dr. Ahn on my left side. We have been doing live cases, I think, now for the last 2 or 3 years. So we know how to deal with each other. He's the boss, and I'm his humble servant in doing this case. Hopefully we have something interesting to tell you with the young fellows and the young physician here assisting. And maybe Dr. Ahn can present the case and greet the audience. Thank you very much again for having me here.
Yes, I'm Dr. Ahn. Yes, it's an honor to have the live demonstration in front of a great audience. And first of all, I'd like to congratulate win the Master of Master this year.
Thank you.
So this case is a very educational case. This is a 67-year-old gentleman admitted to the chest pain and dyspnea, had a history of diabetes, hypertension, stable angina, stroke, ESRD on hemodialysis. Echocardiography showed the severe AS with a bicuspid aortic valve and mild AV dysfunction with some akinesia. So previously he had a history of PCI and ESRD on hemodialysis. In addition, his preparatory was not good and had a history of stroke. Next, please. Diabetic hypertension, hyperlipidemia, and STS score is almost 10. This is a very partner 1 patient. And echo score is 1 is 45, 2 is 4.6. Next. Echocardiography showed the ejection fraction is 48%. Aortic valve peak, mean pressure gradient is 42, peak is 69. Aortic valve area is 0.55. And next. This is his peripheral artery. The smallest external iliac artery diameter is 5.0 right side. But just the puncture site, just below the puncture site, diameter is just 3.0. So I have to do the very high puncture. Next. So this is annulus complex measurement. Short diameter is 20, long diameter is 28. So very elliptical site, elliptical annulus. Mean diameter is 24. Annulus area is 452. Perimeter is 78. Next. This is a sinus valsalva and SC junction. Next. The LVOT as well. Next. So coronary calcium is 300. Our mean coronary calcium is 400. So not so significant calcification on aortic valve complex. Next. The left coronary height is 11. Right coronary height is 18. Next, this is chart. So initially this is our chart. Initially, if this patient have tricuspid aortic valve, we have to choose 29. But the valve selection in bicuspid valve, there is no rule. So we have to discuss later. Do you have any question about the patient history?
Any comments, any questions from your side?
No, it's just he's at very, very high risk, but he's very young, so it's interesting because this is the perspective in the next years to go to younger patients. So he has a bicuspid valve. It's also very interesting, but obviously very high risk.
Yeah, Elaine, and I think we have a couple of interesting points to discuss here. And if I may start with the axis, you can see the axis is 5. I mean, the vessel diameter is 5. The smallest is actually 3.6. I've noticed. So this is really not a large vessel, and I think this is a good case for evolute with the inline sheath. That's going to be a challenge. The other question then is the patient had a history of stroke. This would be if it was available here in Korea. I would probably have a protection device put in with the past history, but since that is not available, we do it without. But just for a discussion point, I think it's going to be an interesting aspect. And then, of course, the question of bicuspid.
Yeah.
And, you know, having passed the last 3 weeks here in Asia and in China and Japan, you know, my head is kind of filled with bicuspids. And the question is, you know, the sizing, the ballooning, which valve. So there's a lot of questions about the bicuspid valve. It looks like I have almost every year we're doing the bicuspids together. So we'll see how the outcome will be. But it's going to be interesting, as Dr. Ahn said, if you take the annulus size in a trileaflet situation, it would be a 29 core valve. Looking at the bicuspid situation, the orifice is around 68. That would downsize considerably the valve size. So before we tell you what we believe is a good option, maybe you and the panel can discuss with us. Obviously, we have to keep a certain time limit, but it would be interesting what the panel and yourselves think about this case in order to give us some guidance.
I'm the team from Taipei. Group A, will you use balloon sizing?
Yes.
Yeah, that's a good question.
Yeah.
I mean, that's the question that that we were thinking of, but you know, obviously that can be discussed because it's not much calcium. I personally, and we've discussed this, we probably would like to do this for various reasons. Number one, I think in a bicuspid situation you can argue with or without. So here, usually I would probably not predilate, but now we can balloon size, and we've chosen an 18 millimeter balloon, and then do the injection, and then see and discuss with you what size valve we should take, given the amount, if so, given the amount of regurgitation with an 18 millimeter balloon. If the 18 millimeter balloon seals or almost seals, I think we would feel comfortable to use a 26 millimeter core valve over the 29 millimeter. If that's massive AI after the 18 millimeter, then maybe we should discuss a 29. But that's open for discussion. And I think it's an interesting situation because you don't have very much calcium. I think it's a good case for us in various aspects. So we do balloon size. That's our plan.
Then why not you use a bigger balloon? I mean, 18 may be too small. You are determined whether 26 or 29. Why not just use a 20 or something?
No, I think the smallest diameter, as you know, is 20 by 28. So I think 18 is a good choice. Obviously, balloon sizes can be argued. I wouldn't object to 20, but I think I'm also fine with 18, depending on the availability. Here in Korea, not all the sizes are available. I think we do have 18 and 20. So we're going to go with 18.
Eberhard, this is Watson with RF from
Hi.
Bangkok. What about measuring above the annulus? Have you done that or think that would be useful?
Yeah, I haven't done it, to be honest.
We already measured it, but the 5 millimeter higher, the annulus area is 200 something, too small. So sometimes supraannular measurement give us very important information, but I don't think this case did not provide us valuable information.
At least it's not getting bigger.
Yeah.
You know, the 6 millimeter rule, I think it's a good one, but also, if I may say, kind of in evolution, not everybody does it, not everybody understands the rationale behind it. The rationale behind it is that the annulus is not the sealing part for bicuspid valves in Tavern, much rather than the leaflets. So it makes a lot of sense to go 6 millimeter higher and see whether it opens or whether it's smaller. So here it is the same or a little bit smaller. So that would not, at least not speak against the 26.
Yeah.
And what about other measurements on CT? You know, there was a lot of discussion about intercommissural distance, etc. Is there someone has an opinion on that, or do you have, Eberhard?
Go ahead. No, I don't, Elaine. Honestly, if I look at the, I haven't seen the echo, quite frankly, because I just got in. But this is an interesting bicuspid. I think it's truly bicuspid. The raphe is there. Whether it's fused or not, I'm not convinced that we're going to break it. So I don't think that the measurements within the valve and within the annulus will help in the decision making. Personally, honestly, I believe downsizing it here from 29 to 26 makes a lot of sense. But as I said, I might be wrong. And obviously, this is something in progress, and we have to discuss how to proceed.
Okay.
The one more thing is, this is the advantage of which our selection of Evolute R. If Evolute implantation there is a huge probability of leakage, we can change it.
Yeah.
One more upgrade sizing from the 26 to 29. I think one very important advantage of Evolute R implantation in bicuspid developed disease.
Yeah, of course, we try to make it right in the beginning, but just in case, as you said, in case there is, you know, we feel it's really widely undersized, we can always exchange.
Yeah.
And then the question to Dr. Ahn, because he's going to be implanting the valve, what his perception is on how to implant, whether he has, obviously he has a lot of experience doing core valves and doing bicuspids. Can you inform us what your plan is in this patient?
Yes.
As far as the depth is concerned?
Yes, usually recently I implanted Eberod in the case of bicuspid aortic valve, a little bit high implantation because anchoring point is, I believe, higher in bicuspid than tricuspid aortic valve. So I tried to adjust 1 or 2 millimeters implanted depth in this case. I'll try if possible.
Well, to be very honest, I mean, this is probably the goal to go by 2.
Yeah.
The downside, if you go by 2, if you are too high,
Yeah.
then you have less options if you have a leak with post-dilatation, as you know. But since this is a bicuspid valve with not much calcium, the post-dilatation with a high implant, you know, there is a certain
Pop-up risk of
risk of the valve slipping up. So my personal preference, but he's the one that takes the case. My personal preference would be a little bit deeper, like 3-4. But we'll see how that works. As you know, we cannot probably go by the millimeters. If we are sealing, then I'm very happy with a high implant because, as you know, the bicuspid valve seals in the leaflets.
Let's do it.
Shall we go?
Okay.
Are you okay? I mean, these people, they know each other, and you know, I don't want to interfere with the stuff, so we can talk and you can ask questions. Dr. Ahn is concentrating on the procedure.
So what side did you select for the introducer? The right one?
14 French for the balloon.
On the right side?
Yeah.
Yeah, it's on the right side, yes. Okay. Yeah, so we do this for the balloon, and then we're trying to get in with the inline sheath only. Obviously, we hope that we don't have to exchange to a different valve, because then we'd have to use a sheath. But the 14 French sheath went up very nicely. That was one of the concerns that we had. But it went very smoothly, and now he's trying with an AL1 to cross the valve. And everybody has its own little thing to pass. What I like with Dr. Ahn is he doesn't poke. So he tries to do some reasoning about where to cross and how to put the guide in. Now, obviously, that everybody does it a little bit differently.
Is it a regular 0.035 wire?
Yeah, I think it is, right? It's a straight wire.
Straight wire.
Not hydrophilic, yes?
Yes, not hydrophilic. Can you show us autogram, please? Okay.
Yeah, so just that you know, the pigtail is obviously not in the non-coronary, but that's not so important right now.
It's usually more difficult to cross the bicuspid than the tricuspid.
Yes, because it's dooming and it's a little bit more difficult, but hopefully we're not spending too much time.
Yeah.
And there is a pacing lead. You will not use it for valve implantation, but for balloon dilatation you will use it, and you keep it for in case of conductive disorders. Yes.
Yes, and of course for the balloon.
Yes.
Now, as you know, in the US, I don't know whether we have it in Germany, I haven't used it, we have a balloon that you can blow up and still has flow. So, but that's not, we're doing it 18 ZMET, right?
Yeah.
Yeah, it's a ZMET.
The true flow balloon.
Yeah, the true flow, exactly.
But how the patient has a stent in his right iliac artery, did you feel any resistance on advancing the sheath?
No.
No resistance.
No, it went very smoothly.
Okay.
Very smoothly.
And can you tell us about the anesthesia? Is he on local anesthesia, the patient, or?
No.
No, general anesthesia.
General
He's on
anesthesia
general.
and TE, yes, we can see TE.
Yes.
Yeah, he's on general. I don't know what you're doing here usually.
Usually the local anesthesia.
Yeah, so
and
deep sedation,
deep
conscious
sedation,
sedation.
conscious sedation. But this patient's underlying condition is so bad, so our anesthesiologist favored the general anesthesia in this case.
Yeah, so this is the life case effect.
Test,
No, but it's
please.
nice you cross live because sometimes cases are done live and you have already everything in place. So we can see how it can be difficult to cross the aortic valve. So it's also interesting.
Yeah, Elaine, you know all the tricks and the problems. I know that.
It just means you have severe aortic stenosis.
Yes.
Please give me the RCA.
And
So as you can
yes,
see, he changes fairly quickly.
Eberhard, if you had no discussion about the size of the valve, would you do a predilation in this patient or go direct? I think you said you would go direct for the valve.
Yeah, for tri-leaflet?
Yes.
Yeah, if this was a tri-leaflet, I would go without, definitely.
Okay.
You know, basically, in Bonn, since I joined, they have changed a little bit I mean, for Evolut, we are fairly restrictive on pre-dilatation. If it is very heavily calcified, really heavily calcified, I think then we do it. In bicuspid valves, we do it, you know, like 50-50 in Lotus and 50-50 in the Sapien cases, and like 90-10 in Evolut.
Will
So
you change to thermal wire in this situation?
So he's doing the right now. He's using the right.
Oh, he
Yes.
did the right thing.
Okay.
So while
I'd like
watching
to
this,
change-
we talked about the risk of stroke earlier, Eberhard.
Yeah.
What do you think about the effect of pre-dilatation and post-dilatation and the risk of stroke? Is there still a belief in any of this at all still?
You know, there are actually, it's very interesting, there are actually conflicting data coming, conflicting data. I can give you examples where you have data that says pre-dilatation does impact injury, and there are others that says there's no injury. I cannot give you any reasoning. My point is, as far as the steps for TAVR are concerned, for me, the best way to avoid this, unless we have solid information, is to do to cut off as many steps as possible that potentially might increase the stroke risk. And among this is obviously pre-dilatation, repositioning many times, and all of that. So I'd much rather save on that. I don't want to call it minimalistic in the sense that Elaine talks about it, like this early discharge and stuff, because we are coming from an area in Germany, we cannot do that. But as far as trying to minimize steps, as you know, I followed the rules. So he put the wire in. Actually,
Yes.
What kind of wire did you use?
Safari wire.
So he's using a pre-shaped wire, which makes
Yeah.
a lot of sense. We're using also Safaris and Confiders. Safari from Boston Scientific and Confida from Medtronic. He put the balloon is in?
Yes,
Perfect.
balloon
So
is
the
in.
balloon is in, 18 millimeter. Do you want me to blow up or you do it?
Okay. So could you help me?
And
Yeah, I can.
what was heparin given
Yes.
Yes,
I hope.
already. Already.
after
So
Prostar?
we maintain the ACT more than 300.
Okay.
Ready? No,
No,
stop.
I don't.
Yeah. Pacing on. Impulsion, please. Deflation. Stop.
Okay, I want to hear what you're
Contrast
thinking
time
now.
is the first.
Well, he injected a little bit early.
Yes.
So,
I agree.
so
Yes.
So, you know, I think actually we're sealing. My point is, in order, because that's really important, I would probably blow up. See, while the balloon is extending, he's doing it now. doesn't, I think it seals. Can we do this again?
Yes.
And
we
you,
can do.
you inject when,
Okay.
once the
Okay.
thing is blown up. Is that okay with you?
Okay, everybody okay?
What about the location of pigtail? Do you think that would affect the?
No problem. Facing on.
Yeah, you check.
Yeah.
Gives it-
Inflation. Contrast.
Good point.
Inflation. Facing off.
Can you take over?
Okay.
Okay, so what do you guys think?
Can you review? Could we review
Review?
it?
Yes.
It's definitely better.
I think we should take a 29.
Yeah, I think so.
Well, you know, you use balloons smaller than the smallest diameter, and you're going to see the leak. And I personally, I cannot judge how much leak this is that would give me the idea of what size of the valve you should.
Why not take a 20 balloon?
Yeah, 20 balloon may have sealed that entirely.
Yeah, you know what? I think you're all right, but the reason here is it's too much to say, you know, even if you have 2 millimeter more, I think we still have a leak. So we will take a 29 millimeter. You know, and the reason why I'm shifting a little bit over now, if this was a calcified bicuspid, heavily calcified, I would feel differently. But now you can see it is still pretty significant. I agree that if it leaks the 18, but that's why we take the 18. Yes, you are right. We have a 2 millimeter lower profile for the balloon, but this is still too much. So we go with the 29.
Yes,
With the 29.
29.
With the 29 core valve for this valve, and I think it's a good
Yes.
choice actually.
It did expand
So we
very well,
minus-
though.
I'm sorry.
It expanded very well with the 18.
Yeah. Well, that goes along with all of this, actually, the way the balloon behaved, the leaks, kind of made me wonder about the 26.
So-
And
How about Rube? If this patient, the aortic valve has more calcified, what's your choice?
no, if it
then-
was more calcified, I think we would have sealed, and then
Yeah.
I think we would have had a 26. That's what I
Yeah,
just said. I
yeah.
think with this less calcium,
Yes.
there's more prone to be PVL, and I don't
Yeah.
think that's a good thing.
So at least the balloon is very stable during inflation. So probably
Yes.
just fit the short axis. And the regurgitation must be occurred from the long axis.
Yeah.
Yes. So we have to wait a
Wait,
little bit
yeah.
because he's loading the valve, and then we're going to proceed. As he said, he's trying a high implant.
Not so high.
No, not so high. We don't want to have a pop out actually.
Yeah.
But you know, and this is a little bit unusual. The bicuspid valves are usually a little bit more calcified. This is not bad, and I think with a 29 we're going to be okay. It does make a difference using the different valve sizes because of the tendency of core valve, if it's widely oversized, has a tendency to dive. But since the evolute times, that's not really an issue anymore.
Eberhard,
So he's-
can you show us the baseline CT? Don't you
Yeah.
think that there is a rudimentary valve leaflet on the 9 o'clock direction? I mean, maybe this truly, it's a pseudo tricuspid, I mean. So
Yeah.
maybe we should follow the charging, sizing chart
Yeah.
using a 29. I mean.
Can you see the?
Yes, I see that this is true bicuspid valve. And this is AP type, left and right cuspid fusion. So type 1, true bicuspid aortic valve.
So
Usually
he's
we
working-
think type 0 would be the true bicuspid.
It's a Sievert type
yeah,
1.
yeah.
Yeah, what
Type
he
1,
means
yes,
is-
type 1.
What he means is not it's not a fused Rafi. It's a genuine bicuspid valve. Okay, so he's almost ready.
We can have a look if you want at the preparation of the valve.
I don't know
Could
whether
you,
he can
could you
turn
show
the
us
camera
there?
around.
Camera, please, over there.
And what did you choose for the vascular access? 1 ProStar, 2 ProGlides? What is your choice in this patient?
I choose just the 1 ProGlide. Sometimes 1 ProGlide works. If 1 ProGlide failed, I will insert more. But in this case, puncture site is so calcified, so I don't like more ProGlide.
Only
If
1
there-
ProGlide?
Yes,
Yeah.
1 ProGlide.
It's quite unusual, no?
Yeah. Are we okay? Perfect.
오퍼레이터가 도피타민 스트레스 해보고 결정하겠대.
Based on this angiogram, there is enough space for evolute 26 or 29 valves. But if the coronary height less than 10 millimeter, which device are you going to go?
I'm sorry, I didn't. Can you repeat that?
If the coronary height
Yeah.
is less than 10 millimeter or so, was going to go 26 or 29 millimeter?
It wouldn't change. It would not change. Now we're.
Depends on the size.
It wouldn't change the size selection. Now we are turning and we look if the paddles are in the pouches, and we have a good load. It looks like it's a very good load.
Yes.
For those of you who don't know the device, you look at the upper part, so at the proximal down part, and you can see the paddles. They're nicely loaded in the paddles in the pouches, so we are good to go.
Okay.
That's an important thing, obviously, that you do this, because if you have a bad load, then
Could you
yeah, if you have a bad load, then you have to exchange and load again, and that takes another couple of minutes. So we're taking the balloon out. The wire is stable. Since it's a pre-shaped wire, I think it's a good thing that we have those wires, because all the problems in the problems with the left ventricle.
No. I have to remove the
Oh,
sheath.
the sheath, yes. So we go sheathless, and he's using the inline sheath.
What is usually the minimal diameter you accept when you do it sheathless? 5?
Yeah,
5.
5, okay.
yeah,
Yeah.
So, but it's good, it's better than
yeah,
not calcified, non-calcified 5.
yeah. Okay, let's see how he goes in. You know, important that, and he does that, if you do access, don't lose sight of the wire in the ventricle. That's a good thing that he does that. Now he's advancing it. Inline sheath went very smoothly, right?
Yeah.
It seemed very
No.
easy.
Yeah, no resistance.
Nice.
Good.
June, please.
Yeah, now we have to go with the pigtail. We have to see whether the pigtail is in the right spot. Take the parallax out. I think the pigtail has to be repositioned.
Test, please.
Yeah. It's in the it's in the right.
Okay.
So he pulls it back and turns the pigtail into the non.
Not easy.
There you are.
There you go.
Okay.
Very nice. That's an important thing. I mean, it's minor maybe for some, but it is important because you don't want to lose a reference. And if the pigtail is wrapped around, so he's going down a little bit. Are you good to go?
Yes. Rotate, please.
Okay. So as you know, this part goes very slowly.
Maybe having the pressure on the screen, if it's possible, you know.
That part, as you know, is going to be slow.
Test, please.
Excellent.
It would be nice if we could see pressure on one of the smaller screen.
프레셔 좀 보이게 해주세요. 스크린에.
To concentrate.
So that's the part where I'd like to concentrate on, both of us, because this is the
Test
part
it.
when the valve goes up. The pressure is
Okay.
still stable, but now the valve
Rotation.
expands, and
Relieve. Okay, good. Slowly. Yeah.
so now you wait because the night node is expanding, and he's giving me good signals.
Just wait for a wait. Stay. Okay. Good. More. Relieve. More. Test, please. Okay.
We leave it there, that's good.
Okay.
So the valve doesn't behave like its typical bicuspid, by the way.
Yeah. Anyway, good sign.
The pressure goes down. Are we okay?
Okay. Test it, please.
Should go quick now.
Okay. Quick release, please.
So that part goes faster. We let the pressure recover. Did you see the pressure?
Yes.
Yeah.
Pressure recovered. Okay. Look at the contrast.
Too high?
That's a zero implant.
Yeah. I need some
I don't know, we
layover.
perhaps
Yeah, so what the situation there is now, remember, we can do a couple of things. So he wanted to do it high. He get it high. So it's at 0 to 1. What I would do now is lay over actually a little bit more
Yeah.
and deploy the valve very slowly, because if we are lucky, then the valve won't move up. But remember, usually when you deploy the valve, release the valve, then the valve moves up 1 or 2 millimeter, and then it would be intraannular, and then depending on the situation. So we have a good diastolic pressure, it's 50. That's quite good.
So let's check the contrast.
would you
Yeah, what he does now is good,
So
because you
ready?
see there's almost,
Ready?
that is very promising.
would you get rid of the parallax a little bit more? Would that help you?
Yeah,
So I like to do the more layover a little bit.
yeah, that I like very much. This maneuver I like. And now, are you okay to deploy?
No, just a moment. Please.
Yep.
Yeah.
See, it's at 0.
Okay. Take contrast again.
Good.
It goes down a little.
Did move
Yes.
down.
Yeah.
So I like to wait for a while till the full expansion of lower part of valve, and then I try to relieve.
So, you know what? Personally, with that type of pressure, I wouldn't inject too many times in the sinus because it doesn't help you make a decision. So what he does now is he's waiting until the night node expands. A couple of minutes. The diastolic pressure looks good. Do we have echo? No, not yet. No?
None yet.
So,
Could you show echo?
What is important
Could you
is
show us
when-
echo?
that I
Echo.
like to deploy the valve
Oh.
against the, against the push. So I don't take the tension out. I push down in order not to give the valve the possibility to move up as much as I can. So this is at 1. For a bicuspid situation, this is just a perfect implant. And you can see where, the cova flag. You cannot say much about PVL right now because you still have the wire in and you inject very close to the annulus, so you don't have the sealing part yet.
We can see the echo.
Yeah, the echo. Can you see the echo?
Yes, we can see, but as said Eberhard, there is the wire in place, etc.
Yeah, yeah.
So for the leak, it's not.
So I think there is no probable leakage.
I don't see any, but,
Yeah.
but I think that it's good. Yeah, it's central, exactly. But that's okay. I mean, you can see this from the angiogram, the pressure, that all looks good.
So I'd like to leave.
So I like to do it slowly, and he's
Yeah.
probably pushing a little bit.
Yeah.
I think it's going down a little bit.
We hope.
Think it moved down, or you pull the pigtail up?
Let's see. Can you inject briefly? Yeah, the pigtail
Okay.
moved up.
All right.
Good point. So let's not move it. Can you push it?
Yes. Okay.
One. Okay, so it came off. Now the next part is very important, that you don't screw up with the nose cone.
You should pull back the wire.
Yeah,
Let the nose cone to be center.
yeah. So he got it off, so there was no problem.
So
And now he's closing it. Blue to, yeah, gray to blue. And now the valve is assembled. We take it out. Pigtail probably will be taken out now, and we'll see what the situation is. See, there's just some contrast there.
okay.
Actually, there is a good. Keep it there. Keep it there.
So could you teach us the precisely or more in detail? At first, the non-coronary site is almost zero position, and
Yeah.
during procedure, it's more deeper. So what did you do during the procedure?
Can we just do the? We come to that in a second. Let's just get this done.
Contrast.
That's good.
I think no probable leakage, but there is some contrast staining around the annulus. So could you examine the echo around
I
the
actually
annulus
think this
point?
is very, very nice. So the non-coronary is 0,
Yeah.
and the coronary is 3/4, which is, I think, is great. The valve didn't behave, as you can see when you deploy it, didn't behave typically like a, it actually behaved like a non-calcified trileaflet.
Yeah.
You didn't see much waste, and I'm really happy we got the 29 in and not the 26. So 26 would have been so small.
Yeah.
So it was a good choice.
echo 좀 보여주려고 해서.
Yeah, look at the echo.
Yeah. No probable leakage.
Yeah, you can see in the short axis, that's actually very good. A very good echocardiographer. She's doing the right thing. She looks at the short axis and see whether there's anything around it. There's nothing around it. It seals very nicely. Position is great. There's no AV conduction. Diastolic pressure is good. Systolic pressure is good. I think that's a very nice result for a bicuspid. And what you said is, you know, you might not have seen it, but when you are at high implant and there is a possibility of post-dill, you want to try not to pull the valve, but to push. You know, very, very rarely you push the valve deeper. Occasionally you do, but you know, here it's a good example where you take off the best practice step, release tension. If you would relieve the tension here, the valve would have moved up more.
Yeah.
So it is important here to push against the valve and then deploy very slowly with push. Otherwise, the valve will move up into a 0 or -1 position, and then for post-dilatation it would have been a little bit tricky. if we had to post-dilate here, I wouldn't mind, because there's still enough anchoring on the left side, and I wouldn't be worried about the non-coronary, which is at 0. So this is really excellent. And at least, I'm sorry, from my perspective, you should obviously have your own opinion, but I think it's a high implant, bicuspid, no leak, good expansion, good hemodynamics. I think there's nothing else we can do or offer, to make it any better. Actually, we don't need to make it any better.
No, thank you. It's very excellent result, as you say. No leak. It was fast.
Yeah.
So really, and it was done in 45 minutes, even much less, because we discussed. So we are just on time. What do you think, my colleagues?
Any other questions? The problem is Dr. Ahn has to go to the other lab to go to Horst. So we have to kind of...
Okay, congratulations for a very successful procedure. Give them a big
hug? I will hug them all.
Thank you very much. Let's move to the another operating room for the preparing already to proceed the procedures. Okay, hello everyone. Yes, let's move to your operating theater, right? Can you tell us what's going on there?
Okay, so my name is Horst Diever, Dr. Maurice Buchbender here, and Dr. Lee will give the case history. Please, go ahead.
Good afternoon.
This patient is 76-year-old female, and she admits upper chest discomfort. He had severe risk factor and DM, hypertension, and stable angina. The echocardiography shows severe degenerative AS with normal LV function. Her past medical history, he had underwent 2 stents in LAD, distal RCA, due to non-STEMI in 8 years ago. Follow-up coronary angiography is normal patent. Next slide. Next slide. SDS score is 2.5 and Euro score is 0.9. Next. Aortic valve Vmax pressure, Vmax is 4.1 liter per sec, and to the planimetry, aortic valve area is 0.5 centimeter square. And next slide. We decide right femoral artery, main device past right iliac artery is no calcium, and external iliac artery size is 8.1. Next. Aortic annulus parameter is annulus perimeter is 66, and annulus mean diameter is 220. And next. Sinus of Valsalva and ST junction ratio is almost reference range. Next. LVT annulus area is 0.8. Next slide. Very low calcium in all of coronary cusp. Next. Coronary height is no problem. Next. Finally, we decide 26 millimeter evolute R in this patient.
Okay, so question to the audience and to the panel. There are 2 things which are a little bit unusual here. Did you spot what that is? What is unusual in this case? Well, at least it would be unusual in our place.
Well, it's a low-risk patient.
Very little calcium.
Very low calcium,
Yeah.
and we have an aortic valve area of 0.5 and very low calcium, so that's a little bit unusual. There's another thing which is unusual. What could that be? It's really a low risk. So Euro score was about 2.5, and SDS score was also very low. So that's something we in our poor country could not do, but it looks like in Korea it can be done, which is actually, I believe, the future, of course. So can we have the fluoro screen on the screen? You see the iliac vessels are looking good, and on CT they measured 7 or 8 millimeters on both sides. So that is confirmed here by the angiogram. We have in place 7 French sheaths on the left side in the artery. We have a venous sheath on the left side with a pacemaker in place. On the right side, we have prepared with 2 6 French ProGlide, and a pigtail catheter is inserted from the left groin, and another pigtail is in the LV. And now let's focus on the pressure. What you see on the pressure there is, and that's something which costs us some time here to discuss, you see a pressure gradient of 20 millimeters of mercury. And my question now to you guys is what to do now.
That's
What do you
why
think?
we are surprised by the low gradient and the severe aortic stenosis by valve area. So
Yeah.
is it low flow, is
Where's-
it paradoxical low flow stenosis? Or?
Where's your aortic pressure measured from?
LV and the side sheath.
Oh, because it looks like there's some delay, there may be
Yeah.
Yeah.
inaccuracy in that.
Yeah, but there was, I mean, we could change it on the pigtail catheter that is measuring in the in the right sinus. But while we were working, it's about the same. So that peripheral amplification is not the big issue. The big issue is the gradient that even with translation of the peripheral, it's about a maximum of between 20 and 25. Which is clearly not the same as what was seen with the AV max velocity of 4.1 meters second.
And remember, the ejection fraction was normal, so ejection fraction was 67%. So how would you proceed in your lab? What would you do? Elaine, what would you do?
But do you have on the stroke volume, I mean, is it a paradoxical low flow
Yes.
stenosis?
We don't have the stroke
No.
volume right now, but we did something that is to kind of explain that a bit. So we debated amongst ourselves, and one of the suggestions was to try to do a dobutamine
Yes.
stress on the table. This time not through an echo, but with the actual pressure measurements.
It's because you have 2 elements who are in favor or not severe. It's the absence of calcification or the fact that the valve is not very calcified and the low gradient. So that's true that we have to know if it's a true aortic stenosis or not. So
So we went ahead and did the dobutamine.
Now let's, can we have a look on the recording?
We
from
started
the
at
dobutamine?
10 and quickly went to 20. Baseline heart rate was 49. At peak, what we measured was at 76 heart rate. So it went from 49 to 76, and we were able to get a max augmentation to almost, I say 40. Our pessimistic friend over here says 30.
20, so
Or
it's an average of 30.
Yeah, so
What you see on the printout, I think, is 25 or 30. Okay. So you can see, I think this is LV pressure of 240 and aortic pressure of, what is that? 215, something like that, right?
yeah, so I think there was a, call it between 20, a mean of 30, let's say, with the translation of the pulse pressure.
and can we
So-
see the valve on X-ray to see
Yeah.
if we see some calcium?
On fluoro.
On
Yeah.
fluoro.
Here you go.
Let's,
Go ahead, fluoro.
Left,
Here we go.
left.
There is calcium.
yeah, no question.
There is
Yes,
calcium.
yes,
mean,
there
it's
is
definitely-
calcium, yes.
Yeah.
It's definitely an aortic
Yes.
stenosis,
Yeah.
there's no question. The point is it severe enough to justify TAVR, yes or no? And at the end of the day, I said this has to be decided by the local team. I must say we would probably just do a balloon valvuloplasty in this case and see how the patient is doing clinically.
But,
But,
what is a valvuloplasty going to do when you're not going to be changing the gradient very much?
Is she
Yeah,
symptomatic?
it will open up hopefully the aortic valve area, but that also should be checked afterwards. But we have echo now in place, right?
What was
Can
the
we-
stroke volume index on the echo?
They don't have it.
They don't have that?
And
Can,
what
can
are
we see the echo? Is that possible?
what are the symptoms of the
No.
patient? Is she symptomatic?
Yes.
This is 3,
He says class 3.
almost 3.
Yeah.
And- okay. Without coronary disease?
No, with coronary disease, she has stents.
Yes, but
But the
without
coronaries are patent.
ischemia.
Yeah, exactly. So dyspnea on exertion, class 3.
with a systolic pressure of 130 when she's walking around, not under anesthesia, and this dobutamine stress echo. So there's an element probably of a low flow, low gradient, but I think that there is more calcification than we have given it either by CT. Look at fluoroscopy, I think it is more.
Yes, I agree. Yes, it's more.
So it is mild to moderate aortic stenosis. Difficult to tell what her symptoms are in terms of the relationship of severity. Probably one thing we would have done is put her on a treadmill and see how much her exercise. Look at the stroke index on the echo. But for the sake of the discussion, I think it's a symptomatic patient with calcified and 30 gradient.
It's still open.
So I heard something from the panelists. Any comments?
It's really just a matter of timing, not a matter of whether she'll need a new valve.
Yeah. So while we're here, maybe the timing is now.
I agree.
Okay.
All right.
Let's do it
So
then.
now that we have a super heart team conference, not only did they have a heart team conference, but we had now another additional heart team conference, and we all agree. So again, the core valve, Evolute R, 26. The perimeter is 68. And we hope no pre-dilatation needed. And what we're going to do is go without sheathless, with just the inline sheath. And that should be enough. So we're exchanging with a Safari wire. Should I help you? Okay, Floro, I'm going to advance the wire a bit more. And we're in good position here. And so the 26 has been prepared. And we're going to go take the 8 French sheath that is existent now in the femoral artery, and then try the valve without dilatation. If it doesn't go, we will go with a 14 French dilator to let the tip of the core valve penetrate into the artery.
Only dilator?
So the dilator is coming.
Let's use the dilator because we had only an 8 French sheath
Okay.
on the groin, so
Okay,
that's
okay,
better to pre-dilate then.
okay. So we're going to pre-dilate. I'm holding wire.
그다음 디바이스. 오케이.
Fluoro, please. Perfect. Okay. So that's one dilatation. Maybe you want to do. Do you have a spreader?
Yeah.
Yeah.
That should be okay.
Will be okay?
Yeah, yeah.
Let's have it here on standby just in case. And let's have the valve, please.
벨 디바이스.
So again, it's the Evolute R, not the latest Pro, but the Evolute R.
Any questions or comments so far?
You know, Horst, this case you placed two Proglide, and the previous case they placed only one.
Yeah.
So
Sure.
do you prefer to use two, or do you think
Well,
it's really
most often one is enough, but if the suture ruptures, then you are happy if you have a
Yes, so
backup.
you prefer to be ready with two.
Did you already check your paddles under fluoroscopy?
Yes, we did that beforehand as we were waiting for the transmission. And Horst now is advancing the sheath, and we can see it. We're holding the wire, and it's going relatively effortlessly. And it's over a Safari wire. And right there is where the calcium and annular and the pigtail. Okay. So the projection, Horst is going to put it in the non-coronary sinus.
Should be almost AP. I think it's a little bit LAO caudal.
Yeah, we are in the AP caudal.
Can I have a puff, please?
Test.
Test.
No,
Test.
no,
Wait,
no.
no, wait. Okay.
A little bit more. Right there. Test again, please. Test.
No, it's not in yet.
It's not in the right core sinus.
No.
So presumably you already checked the valve, I mean, for proper
Yes,
loading
yes,
before
yes.
we
Yes,
came
we
online?
did. Absolutely.
Okay.
I didn't want to do it, but horse forced us to do it.
Little puff.
Test.
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 No, it's
no,
not.
you need to-
Yeah, you have to go
So
there.
you know what I'm going to do? Do you want me to come back a bit? Here.
Oh, let's go back with this.
Yeah, try it. Okay, you try it now, free of the big catheter.
Yeah.
Okay. We're in the LV.
So good result, huh? Come on.
LV.
Look at this.
So this is giving.
That's another
giving,
sign.
giving credence.
That's another sign.
Yeah, it's giving credence against the echo.
So is Dr. Ahn here?
Test. Here we go. That's good.
Okay,
Perfect.
that's good.
Okay, go ahead now. I'm going to hold the pigtail and the wire. Okay, pigtail is held. Okay, keep going. Excellent. All right, so you want to
Okay.
test how about parallax is good? Test.
Test it.
Yeah.
Okay, you can
Do we start there?
Yes.
Okay. Somebody is ready for pacemaker in case we need to. And I'm going to start unloading. And Dr.
Slowly.
Horst will tell us to stop. Give me a test, please.
Test it. Test.
Okay, so far so good. And Horst is adjusting what he needs. And one more test, please, before we flower. It's a little bit, yeah, not too perfect.
Pacemaker 120.
Pacemaker on. 120.
Pacemaker
100 and
on.
120.
Yes.
120.
Yeah.
Okay, test. Good. I'm going to continue
Slowly. Slowly.
slowly.
Wait.
And test again.
Test.
Good. Ready?
Continue. Slowly. Slowly. Slowly.
Test.
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 Perfect. You're keeping it steady.
Test.
Excellent. I'm coming back now.
Test.
Test.
Okay.
Pressure's coming up
Good.
again.
Yeah.
Okay.
Good. Let's do a thinner. Wait.
I have one.
Thinner. I think it's okay.
Okay, yeah, we don't know how. It is a little bit low on the
Yeah.
left coronary side.
I think
We
it will
could-
be okay.
Yeah, we could maybe adjust it a millimeter or so north. That would probably help a bit. What do you guys think?
What depth are you aiming for?
I'm aiming at 4 to 6.
Okay.
Should we
So-
try it?
Let's continue.
Should you,
Huh?
should we? Are we happy with it? This position?
I think so, yeah.
Or so
No,
why
it's-
don't you do me a favor? Let's do a cine and inject just to look at the left coronary sinus.
Thinner?
Inject. Yes.
Yeah, it's okay.
What do you think? Panelist? Hélène?
Well,
It should be fine.
It should,
Yeah,
yes,
I
I
think
think
it
it
should
should
be
be
fine.
fine. It's,
Yeah,
it's not,
higher,
it's
higher
little
than,
but
higher than this would be a little bit problematic.
So I'm removing the
acceptable.
pigtail.
It may come up on the left as you deploy.
Should I do that?
Should you lay over a little?
Go ahead.
Okay, finishing the deployment.
when you lay over, it might be a little
Pushing a
better.
little bit. Okay. Ooh, I could not. Good. Now pull the wire back. And advance the wire.
Okay, let's go.
So what should we do when the gradient now is 20?
We will call somebody. Okay, so let me recapture a bit.
Should you stop pacing?
Yeah,
Oh yeah, pace
stop
off,
facing.
please.
Thank
Yeah.
you for telling us that. We forgot. Very helpful. Stop for a second. Is the 14 French sheath ready?
Yeah, she's
Yeah.
ready.
Fluoro, coming back. Coming back. Are you ready? Okay, excellent. Horse is a one-man band, so it's hard to follow with him sometimes.
14?
I got it.
14?
I got it.
Okay.
And we need the pigtail again, please.
피그테일 하나 주세요.
I'm holding wire. You got it? Okay, so in a second we can look at the preparing for the angio, and then the next thing we need to do maybe is we have a TEE. It would be nice to take a look on the TEE about placement and the paravalvular leak assessment. So,
So the important comment which helped me for the decision was that this valve for sure will degenerate further
some
within
point,
the
yeah.
next 1 or 2 years. And if you implement the German rules here in Korea, then she will not be able to get a TAVR anymore. So that's the point.
holding wire? Okay, go. I have wire. I cannot see the TEE. Are you guys doing the TEE? Okay, advance.
Yeah, it's okay.
Okay.
이거부터 어떤 거?
Do you measure systematically the gradient also? It's just for this special case today? Or?
We always measure the pressure, not so much for the gradient, although we are looking for that as well, but we are looking for diastolic pressure in the LV and in the aorta.
I think, Ellen, I usually do it in order to measure the LVEDP. Sometimes if you have an indeterminate or maybe between mild to moderate angio leak, and then the LVEDP is unchanged, it gives one color. However, if the LVEDP is elevated, it starts to give you another consideration of what to do. But here you can see the
It's good,
diastolic
very
gradient is
good.
maintained. There is no systolic gradient. The LVEDP is absolutely unchanged from baseline. And now maybe we can look at the echo. You could see it on your screen. We have a hard time seeing it, but I don't see any much other than central a bit with the wire, with the pigtail in place, I should say. I don't see much paravalvular leak.
No.
There's trace at 12 to 1 o'clock.
Yeah.
Well, but diastolic pressure is actually pretty low, so we should check an angiogram here.
Okay. Are you ready for the injection?
Yes, it's strange because there is a discrepancy between the diastolic aortic pressure and the echo finding.
Yeah, very much.
Inject.
Okay.
So that's not so good, huh?
Yeah.
Position is okay, I think. So we should post-dilate, huh?
I agree.
Yeah.
How much
So
time
the
do you wait
average-
before deciding to post-dilate an
Huh?
evolute?
How much time do you wait?
Do you
Okay,
let
yeah,
the-
that's a good point, yeah.
It's said to be 10 minutes, but
Yeah.
again, this degree of moderate AR, I think, would necessitate some intervention, and just waiting probably will not solve it to our
I
satisfaction.
mean, diastolic pressure now is 40, and we have actually an increase in the diastolic pressure on the ventricle. It
Yeah.
was 0 before,
Yeah.
now it's 10. And I think
So
this
you,
is something for...
you still have a pigtail inside the LV.
Yeah.
Yeah.
We're going to exchange it for a wire, and we're thinking about dilating the valve.
What was the average diameter of the annulus?
21.
20,
21.
20, huh? So let's go for 22 millimeter balloon,
But no, it was 21, right?
21.
But what about echo? Why don't we see
The
the,
echo looks
paravalvular?
more
We should see
valvular.
it.
A
no?
little bit para.
Yeah, well, it could be para, it could be valvular. So I think at this point in time, what we should do is probably dilate, and if that doesn't resolve it, then we're going to pull back the pigtail and see what is para versus... The echo clearly says not much paravalvular, so I think the angio shows worse in terms of leak than the echo.
Sometimes the evolutor will expand it further in the following a few minutes. So why don't you wait for 10 minutes, maybe?
We could do that if you'd like.
Could some of that been the pigtail that was still across the valve?
Wait.
The pigtail is, yeah, but I think the question is, was it paravalvular or central?
Can we see this?
The echo suggested it was more central,
Yeah,
and your pigtail was still in the ventricle.
Yeah, I would think the echo is crucial in
but
determining
don't you
the.
agree? Don't you agree? Sometimes you can miss the jet unless you have a lot of special views that you can do. We haven't been 100%.
Certainly on the short axis, you could be above
Yeah.
or below it.
Yeah, exactly.
I think pulling everything out, including the wire, and wait a few minutes and redo the angiogram would be a reasonable idea. Wouldn't hurt. And meanwhile, you can try to do echo and look at the AR.
Yeah, why not? I mean,
It's a reasonable approach, but I think that the whole aspect of expansion the same day and the next day partly is wishful thinking, partly is real. But
The valve doesn't look constrained. It looks like it fully expanded at the base.
we can do
let's
another
fluoro
view.
in the other views.
Yeah, Ariel, please.
And the shape of the aortic pressure is good, and it's not for severe AR, like.
Well, now
not
it's
in favor.
actually 30, so diastolic pressure is 30 with the wire across. Can you turn the
Ariel.
Ariel?
Yeah, and I must admit the actual frame is not constricted like you would see when it's all because of underdilated.
Rotate more. More.
Yeah, especially at the concavity, it doesn't seem to be much. And if we dilate, we would dilate with a 22. So maybe waiting for 10 minutes, taking the wire out and seeing what happens.
So let's go on with the pigtail and go out with the wire.
Yeah,
I don't want to pull the wire
that's
across
fine.
the valve.
That's fine. But clearly, as you guys have been saying, the diastolic pressure looks pretty good here on the aortic. You see it?
No. The diastolic pressure is 40.
What was
So
the
that's
starting
not-
diastolic
Okay, it's
pressure?
from the pressure curve. I understand what
Pressure
you
curve, I
Oh,
meant.
okay.
Pressure curve.
Yeah.
What was the pre-deployment diastolic pressure?
50.
Yeah.
The diastolic pressure on the aorta was 50 before.
So it's about the same.
About the same, yes. That's a fair statement. It could very well be predominantly central, and I wouldn't be surprised. The frame looks pretty expanded. There's not much calcium, and we did LEO and REO.
Yeah.
Yeah.
No big change. Yeah.
No.
So you want to take this
the
picture?
But
diastolic
look at
went
the
up a
pressure;
little.
it's getting
Oh,
better.
it's better. It's
Diastolic
better.
went up.
Do you want to take this out? The picture out?
Pigtail is out.
Okay.
Yeah.
All right. Let's have the session.
특이하게.
Okay.
So diastolic pressure is getting better. So it was. But now let's look at the echo.
그냥 없다 그래요?
So now we have what is that? 45, 44.
12시 1시에 조그맣게 있는데
About the same.
It's increasing.
Yeah.
Can we see the echo now?
Coming up. Echo? No leakage? Okay,
No
Dr.
leakage.
An, why don't you go ahead and show the echo? And Dr. An is helping us here, and he doesn't see any paravalvular leak.
Very pinpoint.
Tiny.
Yeah.
And
at
maybe
1
we should
o'clock?
do the long axis too.
지금은 없는
Could we do the
So-
long axis to look at where the feet are?
Okay.
Yeah.
Could you show us one?
And sometimes you
Yeah.
can see the jet there better. And show us where the mitral valve is a bit in the long axis. Yeah. It doesn't look like it is, it's less than the angio's showing. You agree?
Yeah.
Well, let's do another angiogram. Creatinine was normal, so we can do another angiogram.
But what I'm saying is here,
Yeah.
it is less than what you would expect from the angio look.
It doesn't look more than mild.
Yeah.
All
But
right.
let's do another angiogram.
So you want to do it with the RAO or the LAO?
Yeah, go back to the original
Very low,
projection.
okay.
That was LAA 2 and portal 16.
Could you pull the probe back, please?
몇 도예요?
And let's make sure this is not embarrassingly.
No, this is this
Perfect.
one. Yeah?
16요?
Ready?
Yeah, ready.
Inject. Still there, but that's, now
Yeah,
it's
definitely.
less than before. Huh?
Yeah, yeah. And can I do one more, a little bit more LAO, please?
Yeah.
More LAO and less caudal, no caudal. Yeah, the creatinine is normal. And the contrast volume is how much?
1820. 20 delay.
Okay,
Do you want to have one more?
I would, yeah.
Okay, ready?
Yeah.
Inject. Ah, it's still moderate. It's still moderate.
Yeah.
Come on.
More than mine.
Yeah.
1 to 2 plus.
Position is correct.
It's actually surprising. It looks like a good deployment.
And it
And
looks
we can-
fully expanded, right?
We cannot blame a calcium nodule on here.
No.
So we have two choices, or three choices. One is leave it alone. Two is try to dilate one more time within the valve. And three, put a valve in valve.
You know, sometimes we do the measurement to measure the opening of the stent and to see if, for example, if it's less than, if you place, for a Sapien, if it's less than 23 for S3, it gives you some arguments to inflate once more with the balloon. So maybe you see what I mean?
I don't know about this frame with the convexity and concavity. I don't know whether that would hold that measurement. I don't know at which point you would do it.
It was a very elliptical annulus, so maybe that's why it hasn't sealed all the way.
My preference is not necessarily to dilate, because I don't know what we're going to get with the dilatation here.
I mean, what is against dilatation is that the position is actually pretty high. We have no calcium. And
you're afraid to have...
Yes, there's some risk that the valve goes up.
So
then.
to me, that would not be my best chance. My best option is to do a valve in valve. If we want to do
why?
something.
I mean, the position is correct. What should the valve in
I
valve
think
do?
I would do it maybe because of the elliptoid nature, a little bit more, a little bit lower.
No.
Maybe
Can we have AR index?
So diastolic pressure is 40 and end diastolic pressure in the ventricle was about 10.
Yep. And I'll tell you that
So the sister page is 100, more than 25, so it should be okay.
So this is not an unacceptable result. It's not perfect, but it's not unacceptable.
it's on the borderline of, I'd like to leave trace and mild. I think this is both between mild and moderate. So that's what I feel we probably, in our own center, we would work a little bit harder on that.
Well, the downside of valve in valve here is this is a patient with coronary artery disease.
Yep.
And then when you have two valves,
Very
then
good point.
it could be more difficult to get access, right?
Very good point.
And also the position is correct, no? Don't you think
Yes.
so?
Can I have an RAO, please?
So what I would do in our place would be actually to wait a couple of weeks and do the post-dilatation at that time. That's what I would do.
Could we do the echo again, please? I mean, clearly the position on both the non-coronary and the left coronary is pretty good. It is somewhere between 4 to 6. There's not much calcium nodule to explain the problem, and the frame does not look to be constrained in the RAO and the LAO. I agree 100% with Dr. Horst, because I am afraid that with the dilatation we can risk a pop-up. There's not much calcium, there's not much aortic stenotic tunnel between the annulus and the leaflets, and the worst thing you could do is exchange a mild to moderate for a pop-up. So probably the better part of valor is to wait. We have, what do you think, Eberhard? You would post-dilate?
I don't think it's going to be a pop-out. I think the position is perfect. It's not high. I would not need it.
I would not post-dilate. It's not an expansion problem.
Yeah, I think so. I mean, I don't think so either. It's not a positioning problem, and there's no restraining of the frame. You see the frame here. What are we going to affect it? I don't know.
Excuse me, is there any echocardiograph beside you?
Yeah, there is somebody over there.
Yes, we want to hear the echocardiographer's view.
We have the
Can
anesthesiologist.
you tell us the echocardiographic finding with herself?
We have the anesthesiologist who's doing the echo.
Yes.
So there is a mild paravalvular leakage on 1 o'clock.
1
It
o'clock.
reps, yes, and it seems like not more than mild. And there's a small valvular AR. So I don't think that will make a lot of leakage right now.
So you
So
think
you're
it's
saying it's valvular and not paravalvular?
Both.
Both.
It's mostly paravalvular.
Yeah.
Actually, the frame doesn't look too much oval-shaped here, huh?
But from what she said, it is, maybe you can summarize, in your opinion, what level it is.
Dr. He, what is your opinion about this procedure with the mild paravalvular and valvular leak? Dr. He, echocardiographer?
So in conclusion, it looks like grade 2 mild paravalvular leakage on 1 o'clock. So most of the AR is paravalvular right now.
Paravalvular. Well,
Yeah, near the calcium area.
according to your personal experience, it'll be okay or not? What is your opinion?
Well, it's only immediate post-procedure results, so it seems fine for now.
Can you show me the paravalvular again? I don't see it here.
At 1 o'clock.
Is it paravalvular, right?
I don't see it.
It is.
Where is it?
It's a little out of plane right now.
Maybe 3 o'clock.
I think it's very acceptable. I mean, it's
it
grade
is.
2, it's mild, the patient is fine, the blood pressure is 110/40. As said horse, if, I don't know, in a few weeks she doesn't behave well, it can be discussed, but for a grade 2, like mild, I wouldn't do anything right now. Also, you say it will be risky to post-dilate, so why take a risk for a mild one?
Well, it's always that very often we make our decisions according not what we have learned, but what we have experienced over the last 2 weeks. And I had almost a pop-up 2 weeks ago, so I would tend to leave it.
I remember a paper said during the following maybe three months, the leaks will be gone.
Yeah.
Yeah, we
And
have
the predictor. I mean, the predictor is low calcium, so which should be. like
Yeah,
in
from the
this
early
case.
from the early experience of core valve, even way back, we've had 110 patients that were followed at time, and then at 12 months, the core valve US trial did the same thing, the pivotal trial, and showed improvement by 1 grade over the ensuing 12 months from implantation. That data is there, and it seems to be consistent. But I worry about the fact that it is a little bit on more than mild. That's what I worry about. But I think if everybody seems to be happy with it,
How do you think, everybody?
I am. You know, if you think it's moderate now, it will become mild.
How do you think?
Maurice?
Sometimes you have to live with imperfection rather than taking more risk.
Helen, how do you think?
No, I agree that what I said previously. I think
would leave
it's not more than grade 2. It's mild, and if she remains stable, I mean, if she worsen in the next weeks, we can do post-dilatation later, in case.
Yeah.
But today it seems acceptable according to the aortic pressure, the shape of the aorta. It doesn't seem to be severe to me, not at all.
so we have spoken for 10 minutes and more. Maybe we can take another look right now and see if we are trending to unchanged or a little bit better. What do you think?
10 to 15
Well,
minutes?
No, we've done already 10, 15 from the last angio.
Sure.
Well, diastolic
Sure,
pressure is
sure,
going up
sure.
from 40 to 42.
Okay,
It will not
let's
change. Huh?
Let's go ahead.
That will be the same. Huh?
Okay.
Let's
All right?
And she's 76, so predictor of mortality, and I'm not sure.
ready? No,
Yeah,
no.
no, 1 second. It's a little bit too deep, the pigtail. We have
No,
one
no, no,
pigtail
no.
here. There we go.
This is the other picture.
This is the picture.
Yeah, yeah.
Right.
Position is okay, huh? You agree?
No, I would go up a bit.
This one.
That's it. That's it.
That's okay.
Okay.
Huh?
All right.
Ready?
Ready?
Inject. Yeah, it's 1 to 2, between 1 and 2.
Aye.
So I would leave it. Okay, definitely, I will leave it.
Okay.
So, Dr. Sievert, what's your,
Yeah.
what are you going to do now?
I definitely will leave it. I definitely will leave it. This will disappear. If not, I would do another dilatation in a couple of weeks. But I bet it will get better, definitely.
It does clear very quickly.
Look at the vascular closure.
Yeah.
Do we have time to have a look at the vascular closure?
Sure.
Yep. We have 5 more minutes.
Can I have a regular wire, please? Not the stiff one.
Regular wire.
So you're going to be able to put here, to show here?
Close up. Close. And I would like to have the dilator.
2 minutes, okay. All right. 2 minutes. 4 minutes.
4 minutes.
The 14 French dilator.
So do
So
you
I
do...
always introduce the dilator before I pull out the sheath. And
do-
that is because if there's any bleeding, maybe the sutures rupture, then I can immediately reintroduce the sheath to get immediate hemostasis. Let's check the wire position.
And when do you place a crossover catheter? In which case?
Yeah, I mean, I usually do it, but they don't do it here. They don't have the wires available. So in this case, with that good artery, we have a 14 French sheath. I mean, you could almost do manual compression here, so I'm not so much concerned.
Yeah.
Okay.
So let's move a better way.
That's exactly with the 14 French. In the days of valvuloplasty, we used to do manual compression routinely.
It was tough.
Can I have the knot pushers, please?
Do you reverse heparin before removing the sheath?
Good point. Yeah, we can give protamine. Do you have protamine here? Are you using protamine?
Usually we do not.
No.
They don't do.
No.
Okay. We do. We like.
The ACT was 240.
On the suture, not on the clean. Can you see that? No. Let's turn this around. So now I'm pulling back the sheath. You can leave it.
So this is the first.
Yep.
The advantage of leaving the wire at this point is also that you can use an angioseal in addition to the ProGlide if you don't like the result. You're not compressing, right?
No. I'm just holding. Here. Nothing.
Yeah.
So it seems
Should
very
be good.
A
So
little
we
bit,
can,
just
yeah,
so.
can remove
We'll cinch
the
it and
wire.
that's it. Yep. And I'll stop holding as soon as you're done with this.
Chook, you see?
Yep.
Let's actually do it again. So the suture ruptured. That's something I see very often recently. Don't know why.
Good.
In the past, only the 10 French ProGlide, 10 French Perclose ruptured, not the 6 French.
There we go. No pressure.
Perfect.
Perfect. Excellent.
Okay. Thank you very much, Dr. Sievert and
Thank you.
Dr. Lee and other guys. Thank you very much, and congratulations for the difficult cases this afternoon. Yes, let's move to the, we have the 3 more featured lecture start at the 3:30. May I call the first speaker, Dr. Kentaro Hayashida, sorry, from Keio University School of Medicine, Japan. He's going to talk about the TAVI with or without pre-dilatation. Please, doctor.
Okay, thank you very much, Chairman, ladies and gentlemen. It's my pleasure to be here with you today. And I'm going to talk about the TAVR with or without pre-dilatation. And I'd like to ask you, why do we need to do pre-dilatation? Maybe we need to appreciate the whole picture of aortic valve complex by root shot. We can also do the annular sizing by ballooning. And we can also predict coronary occlusion as well as upward motion by septum hypertrophy. And in case of the really severely calcified aortic valve, we need to open the way to advance the device. But what is the disadvantage of the pre-dilatation? I think there is some risk of hemodynamic collapse, especially in case of mitral regurgitation, small left ventricle, and high pressure gradient, as well as it also requires some time. And I would like to give some case example. You can see some calcium link or bridge between LCC and NCC. And if we measure the aortic annulus area, which suggests to use SAPIEN 3 26 millimeter device. But if we see the intercommissural length like 26, and this length was also 21, so we would like to know if this calcium link will open or not. So we performed the balloon aortic valvuloplasty with 23 millimeter balloon. And as you can see, there is no regurgitation at all. And therefore, we chose the 23 millimeter SAPIEN 3 device. And the stent was well inflated. And finally, echocardiography confirmed a very mild regurgitation at all. That means the 23 millimeter SAPIEN 3 was sufficient for this case. So we need to know if the calcium leak may affect the sizing of the valve. That could be one of the reasons for the pre-dilatation. And indeed, for bicuspid case, we need to know which part is the smallest part of aortic valve complex. Of course, the aortic annulus could be small, but at the level of the sinus of Valsalva, roughly never opens. So we need to measure this area and diameter. And I'd like to show this case. This case is the 42 years old, and she had really severe hematological problem and inoperable. And she also had type 0 bicuspid, and her platelet count was 20,000. Therefore, we proceed to TAVI procedure. And we performed pre-dilatation with 20 millimeter balloon. You can see some indentation on the balloon as well as the no regurgitation. So therefore, we decided to put the 20 millimeter SAPIEN 3 device. Because we cannot take any risk to cause a rupture for this case because she's totally inoperable, and we injected again if there is some room or not. And finally, we inflated the 20 millimeter SAPIEN 3 fully. And the final result is the only mild PVL. And for this kind of bicuspid case, we can also put the core valve or evolute R. And we didn't perform pre-dilatation for this case. And finally, it was really difficult to retrieve the nose cone. And because there was a very deformed inflow of the core valve, and the nose cone was trapped by this deformation. So maybe for this case, we should have performed the pre-dilatation. And prediction of coronary occlusion is also very important. And angiogram revealed the occlusion of right coronary, and we put the guiding catheter to protect RCA. And other case shows the 70-year-old female. She has severe mitral regurgitation. Sorry, the movie doesn't work. And for this kind of case, the predilatation may lead to the hemodynamic collapse. So we immediately move to the implantation with the predilatation. Finally, it's okay, but sometimes for this case, you may have the hemodynamic collapse. And if there is some calcium chunk at the NCC, you may have some trouble to cross the aortic valve without predilatation. And we need to put the very good stiff wire like Safari S-Carp to get better support. And we can also use the distal flex to avoid the interference between the valve and NCC calcification. And we can also use the little bit inflating the tip of the balloon. You can see here, because we couldn't cross the aortic valve, we put some air to cross the aortic valve. That is a technique from Dr. Vinny Bapat and Dr. Martin Thomas. And finally, we could cross the aortic valve. But that is the only one case we couldn't cross the aortic valve with a predilatation. The patient has severe kyphosis, like this. And even though we extended the descending aorta with Lundaquist wire, we couldn't cross the aortic valve because the aorta is totally horizontal. And we needed the predilatation from the other side of the femoral axis. Finally, we could deploy the aortic valve. In conclusion, skipping predilatation can be performed in most cases with SAPIEN 3, but not with Evolut R. And maybe, I'm not sure if you agree with me or not. And predilatation should be performed based on appropriate reason, not as routine to simplify the procedure. Thank you very much for your attention.
Thank you very much. Any other comment from?
I think your conclusion was supposed to be, can be avoided with Evolut R, but not with SAPIEN 3. Is that what you meant?
I'm sorry?
Would you say that it can be avoided with Evolut R, but not with SAPIEN 3? Is that what?
I think because the SAPIEN 3 has the better radial force, and for Evolut R, Evolut has less radial force. So usually, maybe in our center, we perform predilatation for Evolut R. Also, we can try, but if it doesn't open, your nose-cone will be trapped.
Are there any criteria to determine whether you should do predilatation or not in Evolut R?
Evolut R, thank you very much. We have just studied Evolut R from this January. So nowadays, we are performing the predilatation for most of the cases, except for the case which has the very small amount of calcium.
So it's quite different from other opinions. Like I think this morning, Eberhard Gruber said he didn't do predilatation for any core valve, Evolut R. So I think it's we need really some probably some data from studies, because it's a question of operator, and it's not very scientific today, no?
Yep, I think so. Yeah, I think it totally depends on the operator experience.
Maybe not experience, just also opinion, because some have a great experience and they prefer to predilate each time because they think that there is not too much harm, and it's
I think just the opinion, I think. My personal opinion.
These days, a lot of predilatation is changing. So now we use selected relatively smaller balloon compared to the XT era.
I think for example, Evolut R, and we use the balloon size of the short axis diameter.
So try to
avoid the
expand more.
collapse.
So for the SAPIEN 3, just pass the cross valve. This is your.
I think we can use the small size of the balloon if we want to open the way to cross the device.
Other comment from the floor? No. Thank you very much,
Thank you
Dr.
very much.
Hayashida.
Thank you.
Our next speaker is Corrado Tamburino from Catania in Italy, who will discuss the complications of Tavern.
Thank you, Hélène. It's very difficult to summarize in 10 minutes all the complications, so I'll start soon with showing the high rate of complication with the first generation of devices that fortunately has reduced with the second generation of the devices according and in parallel with the increased experience of the operators. And this is very important. Only the pacemaker remained high. And let's start with the most important complication that can be predicted and avoided, starting with paravalvular regurgitation. That is a predictor of mortality, has been demonstrated by several studies, at least the moderate to severe degree, but in some cases also the Medtronic advance has demonstrated that mild regurgitation has an impact on survival at long term, together with the partner 2 studies. Which are the predisposing factors for paravalvular leaks? There are some operator predisposing factors, but most of the factors are anatomical factors and technical factors. So we can avoid most of the paravalvular leak or reduce the rate of paravalvular leak by using the MDCT. So in this study you can see very well, this is a study of 4 years ago already, that by regular basis the multi-detector compute tomography, the rate of paravalvular leak has reduced to 5% as compared with 13% without a CT scan. And this is important because together, and we will see later on to the paravalvular leak also, some complications are avoided. Another point is the rate of oversizing that we can reach with each valve, and this is important for the oversizing, and we will see that the adaptation of the valve to the annulus depends also from the oversizing, or in some cases for avoiding other kind of complication, the underfilling of the balloon in balloon expandable valve. Another predisposing factor is the calcium, and we know that the LVOT, annulus, and leaflet calcium, wherever it is a predictor of paravalvular leaks, and the stronger factors are the LVOT and annulus, annular calcification in asymmetrical way. So this is important to keep in mind when we analyze the CT scan in the patients undergoing TAVI. So predicting the paravalvular leak is important by the CT scan. Last factor is the position of the valve. We learned from the initial phase that the higher the valve, and within certain limits, of course, the lower the rate of regurgitation, as well as pacemaker implantation, as well as rupture of the LVOT. But we learned concerning the paravalvular leak that by implanting in the proper position as compared with the virtual basal ring, the F3 valve, and the same is for the self-expanding valve, we have the highest rate of known or trace of mitral aortic regurgitation and a lower rate of mild and moderate to severe paravalvular leaks. So far we have a new generation of devices that aim to address the issue of the paravalvular leak, and this is very important for us. And I would say that with the newest model we have a known paravalvular leak in almost all the cases. And you see here, although these 2 valves are not available so far, the rate of paravalvular leak with the newest devices has reduced together with the experience of the operator and the correct and proper positioning of the valve. So paravalvular leak can be predicted in some cases, it can be avoided or reduced. What about cerebrovascular events? There is a talk about, but I would sum up with 2 slides. There are 3 devices. There are some studies, small studies with a small amount of patients with no clear evidence of a benefit of the cerebrovascular embolic protection devices, but the meta-analysis showed that there is a clear advantage in reducing the cerebrovascular events that at MR occur in 60 to 80% of the patients undergoing TAVI. Although we know that cerebrovascular events may occur after the procedure, also in the first days, hours and days after the TAVI, and within the first years. Conduction disturbances is the only event that has not been reduced with the new devices. Why? Because there is an anatomical factor. The LBB is close to the virtual basal ring, so the lower part of the frame may create a damage in the LBB with compression or fracture. We know very well, by the way, that there are some predictors that are signed with the red star. So the previously demonstrated conduction disturbances, especially the right bundle branch block, and also the type of the valve that can be used. We know that the core valve and the self-expanding valve have more pacemaker implantation than the SAPIEN 3, the balloon expandable valve. What we learned by experience that we have to put the position the valve not so deep into the ventricle, 3 to 5 millimeters, according with the core valve, and we know that the same is for the SAPIEN 3. So there is a correct positioning of the valve that together with the paravalvular leak reduces also by 3 times the rate of pacemaker implant that with this valve is below 10%. So this is very important for the operator to learn this simple rule of implantation of the valve. An issue is the paravalvular, the valve durability is a complication that cannot be predicted, but fortunately we know that there are comforting data that show that there is a good performance of the valve by 5 years with the core valve as well as SAPIEN 3. We have the Rouen experience showing a very good, although small numbers, good performance of the valve. Hélène yesterday has shown other data with a longer term follow-up. The same is with Vancouver experience, showing that there is a freedom from reintervention in almost all patients. We recently wrote as European community the EICTS consensus document that is on publication in European Heart Journal. Is a committee, European committee, and we have 2 definitions: the structural valve disease deterioration and the severe valve deterioration dysfunction. That is the bipostesis valve dysfunction that is important for because it's the condition where we need to reimplant a valve or the patient dies for valve dysfunction. And according with this definition, in our center we have 2% of severe structural valve dysfunction, and the bipostesis valve failure is 4.5% by 8 years. So this is comforting as well. The nightmares are the coronary obstruction, annular rupture, LVOT rupture. The rupture is predictable in some cases, at least the risk, the high risk of a rupture is a rare event and pays a high rate of mortality. The site of rupture is LVOT, sinotubular junction, sinus valsalva, and annular, but we know that annulus is the most frequent site of a rupture, followed by sinus valsalva, LVOT, and STJ junction. And we know that there is a predictor. Can I have the slide again, please? And the predictor is the LVOT calcification. What's happened? As demonstrated by the paper published in Circulation by Marco Barbanti. And sorry, moving ahead and going back, let's move to the coronary obstruction. Okay. Okay. Again, there is some problem. Okay, I go winging it. So the LVOT calcification is the most powerful predictor of annular rupture or LVOT rupture of during the TAVI. The last point is the coronary obstruction. I wanted to show you a slide showing the simple anatomical features. So we have to analyze the width, the depth, and the anatomical takeoff of the coronary arteries, which are here you see the LVOT calcification together with the oversizing of the prosthesis. This is a case example of a patient with no LVOT calcification with an oversizing by almost 40% of the Sapien 26 and had an eventful Tavern, and in this case with a 30% of oversizing but with eccentric calcium in the LVOT, we had annular rupture in the patient. And in some cases when we have how to prevent the rupture in these cases is undersizing the balloon or using a self-expanding valve, and this is what is very important. For the coronary occlusion, this rare is below 1%. It's simple to analyze this slide where you see the anatomy of the coronary sinuses and the takeoff of the coronary arteries, and when you think that there is the risk of a coronary occlusion, it's simple to wire the coronary artery, putting a stent distal, uninflated, a deflated stent distal to the coronary artery, and after the valve is implanted, you can retrieve the stent and implant the stent in case of coronary occlusion. Another point that was discussed before is the balloon valvuloplasty that can predict, in some cases, the threatening of occlusion of a coronary artery. So, my conclusions are that, fortunately, aortic rupture and coronary occlusion are rare, but are life-threatening TAVI complications. The best way to deal with these complications is to avoid them. How? With an optimal aortic root assessment. We have to analyze the annular and sinusoidal Valsalva and STJ dimension, the coronary oste height, the LVOT and the aortic valve calcium distribution, and by analyzing this point, we can predict the risk, the higher risk of complications. Another point is the experienced operator in optimal positioning the valve. We need to develop pre-specified plans and techniques to deal with this complication, like the wiring the coronary arteries is one of the examples. We need to recognize as soon after they happen, the complications, we need to have all the expertise and equipment for bailout techniques. Thank you.
Thank you very much. So, there any question in the audience or in the panel? Okay. Okay, we have to move. Okay, thank you. So we have to move, sorry, to the next presentation on stroke by Dr. Murad Tuksou from Cleveland Clinic, Abu Dhabi. So stroke in aortic valve interventions.
Thank you very much, Alan. Ladies and gentlemen, good afternoon. I will try to summarize within 10 minutes our current thoughts about stroke. Well, when we were conducting the partner trial in 2011, there was quite a strong criticism to the data that we presented at that time, particularly on the point of stroke. And then as you see on this slide, stroke, however you cut it, was much more common in the Tavern group compared to surgical group. Some of us had doubts that recognition of stroke was a problem. Shortly after, or the next big randomized clinical trial in the Tavern era was the core valve trial in high-risk patients, and it clearly demonstrated that in the surgical arm, there was stroke was more prominent, more frequent. And I think this is an important point because they adjudicated their strokes a bit better than we did at that time. Then recently, this paper came out from University of Pennsylvania Medical Center, and then there was absolute chaos in the recognition and reporting of the frequency of stroke after aortic valve replacement. This was a standalone registry type of study in which the neurologists went back and looked at the patients carefully. And it is clear, I think that the message is clear, that you see stroke depending on the frequency of the stroke, depends very much on how much you look at the stroke. We still are learning how to diagnose the strokes appropriately, but it is clear now, more recent trials all employed independent neurological examination in order to detect the presence of stroke and also quantify the severity. When we look at how the strokes fared, really in the real practice, I'm not entirely sure that we decreased the incidence of stroke very much associated with transcatheter aortic valve replacement. Of course, instead of, if you put a valve in to a patient with an STS score of 7 and younger and less atherosclerotic compared to the patient that is 85-year-old and very atherosclerotic and has an STS score of 11, as we have done in the early phase of the trials, that makes a difference. But however, we cut it in the TVT registry, in which we looked at about 53,000 patients that underwent Tavern. There is not a striking reduction in the prevalence of self-reported strokes, and I'm not sure that learning curve plays a whole lot. Certainly, I think the devices that we use played an important role and will continue to play an important role, both the size and the type of the devices, as well as the patients that we choose. Now, when we look at the new generation valves, also we did this meta-analysis for some time ago and looked at it carefully, and that it is about 2 to 2.5% major stroke rate at 30 days. I think that if you get the TIAs and the minor strokes, that number may increase, but the major stroke rate is, or disabling stroke, which essentially is Rankin score 2 or higher, is around 2% to 3%. There is no doubt that any kind of stroke really is associated with mortality. Here, the study that we published last year in Circulation Intervention that clearly demonstrated with these elegant statistical work of Jim Blackstone that even TIAs are associated with less than expected survival in these patients. Now, let's predict this stroke, right, so that we can take precautions. We can protect the cerebral vasculature from the debris that's going to come out. Now, I put some of the studies that has looked at these predictors, and it is really not an easy job to figure out with any meaningful accuracy that which 2 to 5% of patients are at increased risk of stroke, and then you should take extra measures. Of course, it's a whole lot different problem to look at the MRI findings, and then if you call those strokes, then I think we have a big problem in our hands. Anywhere from 65 to almost 100% of patients who undergo TAVR have some sort of an MRI positive event. These are mostly multiple infarcts, or many of them are silent, but they are nevertheless probably associated with 2 to 4-fold future stroke risk, greater than 3-fold mortality, 2-fold dementia, cognitive decline, and so forth. So they don't seem to be benign. Are they causing it, or are they markers? None of us are sure. One thing that we learned over the years is the stroke risk is a continuous risk, but the predominant portion of the risk is the procedural risk that occurs within probably the first week. And as you see in this graph, however you approach TA or TF or TAO, there is a risk of stroke immediately after and within the first few days, maybe up to a week. That is associated with the procedure. So I think that should be taken into account, that this critical period that's related to procedure may be prevented with intra-procedural precautions, such as this one. Neuroprotection, I think this has been emphasized beforehand, so I'm not going to spend a lot of time, but I want to make the point that there is quite a bit of difference in the amount of reds on the left-hand side versus the right-hand side. So this was tested in the Sentinel trial. When you look at the Sentinel trial, it's a negative trial. And that means that they did not meet the pre-specified primary endpoints or many of the secondary endpoints. But when you look at the data carefully, I don't think it is something that we should completely dismiss and put aside. There is some reduction, a 42% reduction in the volume of the new lesions in the MRI, but this did not reach statistically significant. When you look at the mortality, when you look at the strokes, there was difference, numerical difference, and I think that at least should make us pause and perhaps look for future studies. Access complications were very low, so that means that complications associated with inserting these devices into the carotid artery and leaving it innominate is low, and many of them were done with inexperienced operators. Maybe the most important finding was 99% of the patients had some debris that were destined to go to the brain, but was captured by the filter. So that's all kinds of debris, from thrombus to tissue material to atheromatous material to foreign objects and so forth. But nevertheless, 99%. So there is something here that I think needs to be looked at further. And when the investigators looked at the data a bit more carefully and narrowed their analysis of stroke risk to the first 72 hours, there was even more marked difference. So I think that considering the very low risk of stroke risk associated with TAVR, anywhere 2 to 3%, the major stroke risk, I don't think that anybody is, or most of the people are prepared to use this routinely with the available data, but I think we should leave the door open because this is something that is very catastrophic complication of TAVR. There is also some studies, as Corrado pointed out, that with all the shortcomings of meta-analysis, but nevertheless there is a meta-analysis, there's this study that shows that perhaps there is advantage with clinical meaning. In the last minute or two, I'm going to talk about what about these stages, later stages of post-TAVR life of the patient. I think chronic atrial fibrillation plays a very big role in strokes, and chronic atrial fibrillation, new onset chronic atrial fibrillation is not uncommon. Certainly many patients come to the cath lab with established atrial fibrillation. And then for that, we have to look at stroke in a holistic way, in a sort of a larger perspective rather than just looking at the intra-procedural precautions. I think intra-procedural, we have the Sentinel trial. We are waiting for the results of the REFLECT trial. There is contradicting data about pre-dilation and post-dilation, but my belief is if you spend less time you spend in the valve, your chances are less to, your risk is less to develop stroke for the patient. And the Bravo study demonstrated that we can stick with the unfractionated heparin rather than using more expensive anticoagulants. I think for atrial fibrillation, we have a lot to learn. There's many studies that is going on for atrial fibrillation, how to manage these patients. Should we add dual antiplatelet therapy to anticoagulants, or just stick with one antiplatelet for a short time? I think, should we use NOACs? And then also we are starting a study to look at the role of the left atrial appendage occlusion in patients with atrial fibrillation. That's the WATCH TAVR. And the same thing with the valve thrombosis. What is the relationship of valve thrombosis with stroke, really? I mean, we have so much valve thrombosis, it looks like, and so few post 30-day stroke. Can we make the linkage reliably, and can we use anticoagulants for that purpose? We will see. There are a bunch of studies coming up. In summary, stroke after TAVR is an important problem, and the rate of post-TAVR stroke is less than post-surgical AVR stroke. Stroke and TIA are clearly associated with increased mortality and morbidity, and risk of stroke is predominantly procedural. However, atrial fibrillation is an important factor after the procedure, probably after the first week or 30 days. If TAVR stroke risk can be reduced further, it can be another differentiated feature from surgical AVR for preferring TAVR. And procedural variations, embolic prevention, And post-procedural treatment may help to reduce the risk, but we have some work cut out for us yet. Thank you.
Thank you very much. Thank you. Any question? Oh, sorry. Any question in the panel? Or do you think there is on one of your last slides, you have the procedural stroke, the EF, and the valve thrombosis. What is, do you think there is a link between AF and valve thrombosis? I mean, do you think it's only a question of treatment for valve thrombosis, or maybe it's because patients, I don't know, receive treatment and don't have thrombosis? It's really separate, or?
You mean the valve thrombosis and the stroke risk? Is that,
yes.
Is that the question? You know, my question is, we see stroke after the procedure, 1 to 2 years. We have data with that. Most of the strokes occur early on. It's a minority occur in that period. But we have 15% stent thrombosis early on. We don't even know how late it goes. So I think that we have to do more work and more data to associate them, rather than just anecdotal associations, before we just say flat out that we have to treat all these patients with anticoagulants. Because don't forget, many of the patients that we treat now with Tavern have indeed high CHATS-2 scores if they have atrial fibrillation, but almost uniformly they have high blood scores as well, high bleeding risk as well. So I think there are much more work we have to do instead of jumping because of the pictures.
Okay. Thank you very much. So I think we have to conclude. You want to conclude?
Yes, I appreciate all the speakers and the panelists and audience, because we have a little bit behind the schedule. Let's conclude this session. Thank you very much all.